Okay. So we will discuss today the cardiac catheterization and ECG, inshallah, and we will finish our cardiology section today, inshallah. Okay. So cardiac catheterization is basically one of the investigation mode, okay, like echo, ECG. So it's an invasive procedure, and we perform this procedure to diagnose as well. Along with that, we can also estimate the pulmonary hypertension and other things as well. So for these days, because echo is a one which is a very good investigation. So we have different modes of echo like trans we can go for transthoracic, trans esophagus. So that is why we don't need cardiac catheterization so oftenly for the diagnostic purpose. Okay, but for your exam, they basically want you to diagnose the underlying cardiac condition on the basis of the data they will be given. Okay. So we will discuss today some examples. Okay. Along with that, I will share some practice material for cardiac catheterization as well. Some files I will share with you. So if you will going to solve all those things, so you will be master in, managing this question. In the task section, they oftenly give one question for this section, cardiac catheterization. Okay. So let's start. So first of all, when we are discussing the cardiac catheterization, we should know the normal parameters. Then only we can detect the abnormal. And for normal, you have to know the two important things. Like over here in this section, in this table, it is mentioned that you should know the saturation for each compartment. Along with that, you should know the pressures as well. So these two are required when you are managing the cardiac catheterization. First of all, we will going to start with the saturation part. So if you start with the saturation part, you can see that the first of all, you will start with the right atrium, and the right atrium is taking blood from the superior vena cava or the inferior vena cava. Then we have a right ventricle, then we have a pulmonary artery. Okay. So always remember the pressure, the oxygen saturation I'm talking about in each compartment will be same. So if you start with the vena cava, either it is a superior or inferior, the oxygen saturation of the right side department is around in the 70s. So just remember the word 70s if you cannot recall the exact 75. So I'm not, exact figures are not required, but you should have an idea that the right side saturations are in the 70s. So the 75 is the saturation of the superior or inferior vena cava that drain into the right atrium. So the right atrium saturation will also be the same 75. Same blood is draining into the right ventricle, so the saturation will remain same 75. And from the right ventricle, the blood enters into the pulmonary artery. The saturation of this right side compartment is around in 70s. You just remember the word 70s. Sometime, in your when you are solving the different questions, you can see that the right atrium saturation they give you in 68. So the figures is around same, around 70. So you don't need to worry. Yes, if it's the saturation is about 50 or 80 or 90, that is a different, this is not a normal. Okay. So 68, 70, 75, 72. So this is the normal variation of the saturation of the right side. Okay. Now we talk about the left side. Okay, right side, you have to remember 70s. Now, when we talk about the left side, again, we start with the left atrium, then we have left ventricle, then we have the aorta. Okay, so in this all parameters, what I told you, in a normal person, our saturation is around 94, more than 94. This is a normal saturation. So you expect more than 94 in this compartment. Started from the left atrium, it should be more than 94. It should be in the left ventricle, it should be more than 94. Same goes to the aorta, it should be more than 94. Okay. So the saturation part becomes simple. Now you can easily memorize the saturation, a normal saturation of the right side and the left side. Now we come back to the second part of the cardiac catheterization, which is related to the pressures. Okay. So when we are discussing the pressure, again, it is further divided into the right side and the left side. So the important pressures which you should know is that the atrium pressures are almost same. Okay, so when we talk about either the right atrium or the left atrium, I'm talking about the atrium, the pressure is around 3 or 8. You do not need to remember, just remember the word 5. Okay, so 3 to 5 for right side, and left side is also the 5 to 8. So just remember the mid term 5 for the atriums. But when we talk about the left ventricle or the right ventricle, we all know that in our blood pressure is around 110 by 80. So our left ventricle pressure is of same, just like our blood pressure normally we assume. So in this picture you can see the left ventricle blood pressure is around 110 by 80, and the same blood from the ventricle transmit into the aorta. So you can see the aorta pressures are also same. So you have to see both the chambers. This is very important. When you are you will see that whenever there is an obstruction in between it, for example, this is the left ventricle and this is the aorta, what you expect normal that in the left ventricle it is 110 by 80. In the aorta it should also be 110 by 80. But for example, if there is a midway obstruction, stenosis is there, for example, aortic stenosis is there, valvular stenosis is there, so the difference of the pressure, the pressure will not be same. The pressure will not be same. There will be the difference. So you always remember that pre stenotic, before the stenosis, before the obstruction, the pressures will be very very high. And because of the obstruction, the blood, definitely the amount will goes into the aorta will be of smaller quantity. So the post obstruction, or you can say the post stenotic, the pressures will be low. So there will be the difference of the pressures between the ventricle and the aorta. So you have to see both chambers, the pressure would be same of the left side. Same goes to the right side. We all know that the left side is our predominant side, while the right side is not the predominant one. The right side pressures are decreased. So the normal right-sided pressure, you should remember the 125 around, and the same pressure goes to the pulmonaries as well, the 25. Again, it is very important to see the difference between the right ventricle and the pulmonary artery pressure, because most of the conditions, like when we are talking about the left to right shunts, PDA, VSD, all these conditions, whenever there is increased pulmonary flow is there, ultimately pulmonary hypertension occur. When pulmonary hypertension occur, the pulmonary artery pressure increases in that situation. Okay, same goes to the Eisenmenger syndrome, that the pulmonary artery pressures are way up, just like the aorta, 110 by 80, something like that. So the pressure important is pressure are also very important. What I told you, whenever we are managing such a large VSDs, or when we are planning to go for the surgeries of a large VSDs in older children. So we check the pulmonary pressures through this cardiac catheterization. Cardiac catheterization not only tell you the pressure, but it also tell you about the reversibility changes as well. That whenever we are giving nitric oxide or sildenafil, whether the pulmonary pressures are decreasing or increasing, so that all information can be extracted from the cardiac catheterization. Okay, so now we discussed the normals in detail. Now we will going to see how you're going to approach. Now we will first discuss the approach, and then we will solve some examples, and that example will be solved by you people. I'm not going to solve it. I will give you the approach, and then you will going to solve the example. Okay. Okay, so some participants came late. So tell me, you people have catch up or not, or should I tell you? So I'm just summarizing for everyone, because you have to solve the examples. So that is why I'm summarizing. The important thing is that whenever you are dealing with the cardiac catheterization, just check two important things: saturation and the pressure. Start with the saturation. The right-sided saturation start from the inferior vena cava, blood goes into right atrium, then ventricle, then pulmonary artery. The saturation of all this compartment is same. Just remember the word, the saturation is around in 70s. There is no fixed value for that. When we talk about the left side from the atrium, ventricle, aorta, we all know that our normal person saturation is more than 94. So this compartment, the saturation again is more than 94. Could be 95, 96, 97, 98, but just remember more than 94. Now, when we talk about the pressures in the atrium, either it is a right atrium or the left atrium, the pressure is very small in the atrium. You can see the atrium and the left pressure. Just remember around 5. This is normal, okay, around 5. When we talk about the ventricles and the aorta or the respective, vessels, when we talk about the left ventricle, the left ventricle and aorta has the same pressure, just like our blood pressure, 110 by 80, 110 by 65. So just remember this 110, 110. When we talk about the right-sided pressures, they are less as compared to the left ventricle. So remember the term 25 for that. That is a quick revision for all which we have discussed. Now we will going to, approach. So when we are talking, approach, so you can see over here, there is an example in front of you. Okay. So this example is basically, okay. So when just we have another example. So this type of data like this in your exam. Okay. So in your exam, you will get such a data that they will going to mention the saturation separately and pressure separately. So the first rule whenever you are approaching towards, because your aim is from this data, your aim is to diagnose underlying cardiac lesion, underlying cardiac congenital heart disease. Okay. So first thing is that start with the first rule is that start with the saturation of the aorta. Listen it very carefully. This is the first step that you have to start with the aorta saturation. So when you look at the aorta saturation, that is 97. So now your mind clearly, categorize that now you are dealing with the situation which is acyanotic, because your saturation is more than 94%. You are not dealing with the cyanotic heart disease. So if whatever in your stem, the cyanotic heart diseases are there, which you have discussed in our previous, just cross it, simply cross it. Now your concentration will only be towards the acyanotic heart diseases. This is the first rule. Now, what is the second rule? So I'm just, telling one by one. So what is the first rule? First, check the saturation. This is a very, very important slide. You can take a screenshot for that as well. This is the quick summary of, solving the cardiac catheterization question. So first, check the saturation of aorta. That will categorize it. Either you are dealing with the cyanotic heart diseases or acyanotic heart disease. Now the second step is follow the pressures and the saturation. So how you going to follow it? So everyone has own ways when you will going to solve many questions. So there will no need to make a diagram, but in your exam you will have a plain paper along with you. So don't worry that how can we make a diagram on a computer. When we are solving, you will have a plain paper along with you. So, okay. So you can make a diagram as well. But when you are solving many questions, it will be habit for you. It will be a practice. So follow means that this is the right side. This is the right side. This is the left side. So right atrium saturation is 88. Right ventricle saturation is 87. Now you can see the pulmonary artery saturation is 87. Now start with the left atrium first. Left atrium is 97. Left ventricle is 97 and aorta is 97. So you just follow the saturation. Now the time is to follow the pressures. So when you see the right atrium pressures, it is 5. When you see the left side, right ventricle, okay? Sorry, right ventricle, I'm sorry. When you look at the right ventricle, you can see the pressure is around 35, okay? And when you see the pulmonary artery, the same pressure, that is 35, okay? So you all are, be with me, you are following with me, okay? Now back to the left side. The left atrium pressure is 6, okay? Left ventricle pressure is 100 by 8. And you can see the aorta the left ventricle pressure is 100 by 58. Okay. So now you have trace it. Okay. You have follow patients, you have follow the pressures. That was your next step. Now, third, detect the abnormalities. Now, marked it with the color, circle the abnormalities. So over here, I have different colors, so I can use the different color. You can circle the abnormality. So let's start with the right side where the problem is that. So when you see that in the right sided, what you see that the saturations are quite high. What do you see? From the right atrium, what we learned that the normal is around in 70s. So the problem started from here. Is that so? You all are following with me? So they started with the right atrium. So problem started just at the level of atrium, okay? Because saturation is increased from the atrium, okay? Same saturation goes into the ventricle, okay, no problem. So if there is a problem, if there is a first just highlight the abnormality. When you will going to highlight abnormalities, then only you can able to interpret them. Okay, so you have already circled the abnormality that at the level of atrium I can see that there is a increase in the saturation of the step up increase, or you can say step up of the saturation on the right side. And that step up I noted at the level. Now I have to see the level as well, at the level of atrium. Okay, they did not give in you the saturations of C or IVC. So if they mention, then you have to draw the SVC or IVC, and you can write the saturation or pressures over there as well. Okay. So I've already marked the 88 is the abnormal value. Then I goes to the right ventricle. I can say, okay, the same blood is going into the ventricle. Okay, I agree that. Okay. Then pulmonary artery, okay, 87 saturation, even though it is high. So it is all high, okay, all high. But the same amount from the atrium enters into the ventricle, enters into the pulmonary. The saturation is remains same throughout the compartment. So just listen the word carefully, that even though I notice the step up of the saturation at the level of the atrium, but when the blood is going from the atrium into the ventricle, then pulmonary, the saturation remains same. Okay. Now, when I see the left-sided saturation, that is okay. I cannot make it with red. Saturation of the left atrium, left ventricle, and aorta is normal. So I'm not marking it with the red. Now, what I can see over here now, there is a time to see the pressures as well, okay? Before going into the conclusion, it is very important to look for both the saturation and the pressure simultaneously. When we see the pressure right atrium, that is okay. 5, I say, just remember the word 5. It's okay. I'll accept it. 3 to 5, I'll accept it. But when I come there at the level of the left ventricle, what I can see in the left ventricle, that the pressure in the left ventricle is slightly right ventricle. I'm sorry. I'm confusing between right and left. I'm sorry for that. So when I goes into the right ventricle, what I can see that slightly increase in the pressure. Are you agree with me? What we learned for the right ventricle?
Yes.
Yes, we learned 25 for that. Okay. So I marked it with the red. Right ventricle pressures are slightly high. Same goes to the pulmonary artery as well. That is also 35. When I go back into the left-sided pressure, atrium is okay. Left ventricle 100 by 8, okay. But when I goes into the aorta, I find a very abnormal thing. Can you see the diastolic difference? 58. This is a this is 58. Don't you think this is such a difference between the diastolic? When you see the normal values, that is okay. So for the normal values, this is okay. Left ventricle, this is the normal value they've given you. That in the left ventricle, 100 by 8 and 110 by 65. So this is normal, okay? The diastolic difference is normal over here. So this is normal, okay? Little bit, a slightly change, but it's okay. So where the problem is, So when we are seeing this question, what we are concluding that two problems are there. What are the two problems? So first we follow through it, then we detect the abnormality. Once we detect the abnormality, then we have to look at the level where the problem is, whether there is an increase in saturation, decrease in saturation, or where the level of the problem is that. So what we detect in the conclusion, that there is a step up of saturation at the level of the atrium, and there is also increased pressure of the right ventricle and the pulmonary artery as well. Okay, so artery levels pressures are also increased, and you can see the top of the saturation is that. So what do you think? Why? Now there is a time to diagnose the condition. Now there is a time to conclude and make these important information into one disease. So what my disease would be? First, acyanotic. You all going to agree with me because of the saturation of 97. Now if because I'm dealing with the acyanotic, I'm not going to think about transposition of the great and that the TAPV. I'm not going to think over it. So what I see over here, step up. So how this step up occur? How this step up occur? Step up occur can only be occur if there is some connection. Okay, if some connection, you can see this is the our left atrium. Okay, so this is our left atrium and this is right atrium. How can be a increase in the saturation? Only possible if blood flow from the left atrium into the right atrium through the left to right shunt. Remember this shunt as well. So blood is coming from left to the right side. That is why there is an increase in the saturation, because oxygenated blood coming from the left atrium into the right atrium. So the blood amount is going more in the right atrium. Is that okay? Okay, so probably because the right ventricle receiving the same amount of the blood, so I cannot assume any connection in between it. Okay, because there from the right atrium into the right ventricle, there is no change. So there is no shunting across the ventricle. Now the blood goes into the pulmonary, the same amount, the same saturation goes into the pulmonary. So there is no shunting. So what I'm suspecting, just seeing on that, there is a shunting at the level of the atria. If there is a shunting at the level of atria, probably we are dealing with the ASD, atrial septal, septal, defect, atrial septal defect, ASD. Now you have to explain the pressures as well. Okay. So we all know that because of the left to right shunt, any diseases which is having left to right, they are the right side receiving more blood. Okay, so if the right receiving more blood, they has to pump against more blood. They will gradually, the pressure will going to be increased gradually. So this rise in pressure is basically telling me that the in the right side is more. That is why the pressures are gradually increased. Condition are associated with more blood in the right side. And remember that the problems start at the level of the atrium, right atrium. So probably this is the ASD. Okay, so now I'm deal with the ASD. Okay, is that clear to everyone? Okay, any question? If you have any questions, you can ask. Feel free to ask any question due anytime. You can
Madam,
write, you can interrupt me. Yes.
madam, if there is a connection between uh, LA and RA, so what about the pressures? Should the pressures be raised or they will remain the same?
Precious you can see because the amount is going more. Okay, this amount is from side goes into the right side more. Okay, what you do when you want to increase your muscle? Start lifting weights. Is that so? So
Yes,
just
madam.
like because you are dealing with more amount of blood, the muscles will become thickened. Okay, will
Madam,
be strong.
basically I was asking, what about the pressures in RA and LA? Will they remain the same or they will
They
increase?
also increase little bit
Okay.
increase. See, the normal right atrium pressure is 3
Yes.
because the atrium is the one which is have a very thin wall that is not designed to force the blood. Okay, that is just a reservoir. You can see the main amount of the blood is specific. Okay, so right ventricle is not that much working. It is the one just act as a reservoir. Those who are working, because ventricles are the one which are working against the this for example the aorta or the pressures. So they are the one which get hypertrophied. They are which you can see the significant pressure differences. So and the left atrium you get the significant pressure difference. Okay, little bit slight because it's just a reservoir. Okay, your question.
Okay, madam. Thank you.
Excuse me, ma'am. Ma'am, why pressure is normal in left ventricle when there is defect of AST? Pressure in left ventricle should be decreased, but it's normal in left
No,
ventricle.
this is by God this made strong. Okay, so this is the one which is thick. The walls are thick in already left ventricle. Right ventricle walls, by nature it is thin out. It is thin. So because this is the one which is working normally, even it's working now, even though it is receiving a little blood comparatively, because you can see shunt is not that much significant. Do you think from left atrium to right atrium there will be a very significant blood? No, the shunt, because this is a small reservoir, no such difference will not be significant. So yes, the blood will be decreased comparatively, but not that much. Will be increased, but not that much. So it definitely the pressures will remain same over there because it's working against the aorta. So the aortic pressures are, when the ventricles reaches to the above 100, then only the aortic valves open. So the ventricles are contracting against more than 100, then only aorta is opening. So they are working accordingly, properly. That is why their pressures are okay. You got it?
Yes, ma'am.
Because the right side is the one which is receiving extra volume. They are the one which is bearing weight. So they are gradually increasing their bulk. They are increasing their muscular bulk. That is why they become more stronger and stronger. Ultimately, if you will not going to correct this shunting, ultimately they will be as powerful as the left ventricle. Okay. So when the child will be in, if it is an ASD, if the child will be in 30s, their mass will be as equal to the left ventricle. Okay. So these are the rules. So just revise those rules. So first we check the saturation. Now it's your time to solve. Okay, I've done my part. So first check, start with the saturation. First check saturation. Then follows the pressure and the saturation around heart, vessels, and chambers. Okay, and noting any deviations. Okay, where is the change? Then once you have note the change, then check there is an increase in the saturation in that chamber, or there is a decrease in the saturation in that chamber, or the pressure. Saturation or pressure, you have to look at simultaneously. Then once you have exactly categorized the point where the saturation either going up or down, then you have to mark that level. That if the problem start at the level of the atrium, then problem is at the shunting is at the level of atrium. The problem is at the level of atrium. Then this is important point which I mentioned, we will going to practice as well. Compare the pressures between the ventricles and the artery. This is very, very important to check for the stenotic lesions. So if you have an obstruction between the ventricle and the artery, then there will be a difference in the pressure around the ventricles and the artery, and we will going to see the example as well. And in the last, this is a very, very good point, that if you can see that the ventricular pressures between the right and the left are same. Listen it very carefully, that if your ventricular pressures between the right and the left side are same, that means there is a large ventricular. So we have three differentials. We have large ventricular septal defect, you have Eisenmenger syndrome, you have common arterial trunk, that is truncus arteriosus, or you have tetralogy of Fallot. So you have these four conditions in which the pressure of the right ventricle ventricle is normal, equal, right? There is no difference between the right and the left ventricle pressure. Means divided, the right ventricle also have something and left ventricle also have 100. So if you have a pressure both, that means a very large VSD, or you have Eisenmenger syndrome, or you have truncus arteriosus, that means a large vessel coming from both atrium, or you have the TOF. Okay? Clear to everyone? Now who will going to do the first example for me? First example, I've already done it. This is atrial septal defect. I've already told there is a rise in saturation of the right atrium that indicates shunting at the level of the atrium. Because our saturation, aortic saturation is 97, we are dealing with the acyanotic heart disease. So the conclusion is ASD. Okay, who will going to do it? The next. I'm going to help you, no worries. I'm going to
Madam, I'll
otherwise.
do that.
You will going to do what's your name, doctor?
Madam, Saad.
Very good. Okay, let's start, Dr. Saad. First of all, what my first step?
So, madam, the first step is to see the saturation in the aorta, which is normal,
Very good. Very good.
95%. So this rules out any cyanotic heart disease. So
Very good.
this means now we're dealing with the acyanotic condition.
Good.
So
Very good. Now I have made the picture as well because you're practicing. So that is why picture. So let's start.
yes, so madam, the saturation in SVC is normal, is 75.
Okay.
RA is normal, RV is normal, 75%.
Okay.
And
Okay.
in the pulmonary artery, it is 88%. So this means there is something wrong here.
There is something problem at the level of artery level. Okay.
Arterial level, yes.
Bilkul. Abhi just I know this artery level problem. Very good. Now
Yes.
come back to the left side.
On the other side, LA and LV saturations are normal,
Very good.
and the pressure is normal in RA. The
Hmm.
pressure is RV. This is
Hmm.
raised. This is
Very
raised.
good. Very good.
This should be around 25. So
Yes. Very good.
and on LA pressure is also raised.
No, it's okay. 5 to 8. It's okay.
Okay.
Hmm.
Hmm.
LV pressures are also okay.
Yes. LV pressures are normal,
And
and
pulmonary pressures are also
pulmonary pressures
okay.
are also.
Okay.
Madam,
Okay.
pulmonary
So I'm
pressures
just
are
changing the.
raised.
It's okay. Aorta. Sorry. I'm sorry.
Yes.
Aorta
Yes.
pressures are also normal.
Yeah.
Okay.
Yes. Yes. It's normal.
I'm changing the color for you. Now tell me where is the where is the change?
Madam, change is
Pulmonary artery.
at the level of pulmonary artery.
Very good. Okay. So you mark the change. You mark the change. Okay. Very good. Don't be hurry up. Don't be in hurry, doctor. We are dealing one by one. Don't be hurry. Rabia, just don't give any answer because if you will throw an answer, that other person thinking will stop right away. Okay, so don't throw your answer. Rabia, right up. Just wait little bit. Sorry. Okay. Okay. So very good, Dr. Saad. You have detected the abnormality. Now, once you have detected the abnormality, then tell me where there is a step up or step down of saturation.
Madam, there is step up of saturation.
Both step up of saturation as well as pressures. Okay.
Pressures, yes, yes.
Okay. So where is the level? Now tell me when you have decided the step up. Now tell me the level. Where is the level?
Level is, madam, pulmonary artery.
Very good. Artery level is means that if it is a step up, that means I'm assuming shunting. Is that
Yes,
so?
yes,
I'm
yes.
assuming shunt. Some blood is coming from arterial level from aorta to the
In,
artery. So what do you
yes.
think? What is this?
PDA.
Very good. See? So
Yes.
this is
Yeah.
PDA because you are dealing with the acyanotic heart disease.
Right.
So PDA, ASD, VSD, all are associated with left to right shunt. That is why you have high pressures in the ventricle as well as pulmonary artery. Okay, so these high pressures also explain because it is left to shunt.
Right shunt.
Okay, so
Okay,
Rabia, you
madam.
were saying what you were saying in the answer is, just let me check your chat. What was your, you say what you said? You said you deleted. I think you have deleted. So I think you said pulmonary stenosis. See, in the pulmonary stenosis, what would happen? There will be difference. The pressures will not be same. See, the ventricle, right ventricle and pulmonary pressure both are same. So if both are same, it could not be any obstructive lesion. It could not be any stenotic lesion. Okay. Thank you so much, Dr. Saad. Now, next question. Okay. So see, we have said there is a step up in the saturation at pulmonary artery level, means shunting at the vessels level. As our saturation is 91, so we are dealing with the acyanotic heart disease. So what we concluded is patent ductus artery. Now who will going to do the next? I'm asking because I don't know the feasibility of everyone. Na? Maybe someone busy. That's why I'm asking. If anyone is free, come up. Come up. If you will say, you will learn. Don't shy.
I will.
Who will going to come up? Yes,
I'm
that's
do
great,
it.
Ariba. You can try. Okay, let's start. What our first? Start with the first step.
Aorta,
Very good.
aorta, which is 88%, less than 94%. So we are dealing with cyanotic heart disease.
Very good. Now next step is follow. Okay, so I'm just making a ventricles and heart for you. If you have a problem, you can make it. If you don't have a problem, you cannot make it. Okay, start with the SVC. Okay, so just keep it in mind. We are dealing with cyanotic heart disease. Okay, so in the
Yes.
SVC, what we have?
SVC, IVC, and right atrial, both pressure around 70%, above 70, 68, 64. 64 is lesser. Can we consider it normal?
Yes, we are normal. But because IVC, SVC just okay, not a very great difference. 3 to 4% saturation, that is okay. Just make it normal. Okay. So
In
right
right
atrium,
ventricle,
you are right. This is 72. Okay. Then what you
in
can
right
see?
ventricle, there is a rise in saturation, which is
No,
84%.
don't come up the conclusion. Just follow it now. Okay. So
Okay.
first follow everything. Okay. So this is 84. Okay. And
Yes,
then pulmonary artery
which is
85. So
85.
first follow all. Then we will going to mark it. Okay. Now back
Okay.
to the left side. What is the left atrium?
It is 98%,
Very good.
and left ventricle is 91.
Very good.
Now,
And aorta.
yes, it is 88.
Okay. So this
Yes.
is the saturation. Now make the pressures as well side by side. So right atrium pressure is 12.
Is raised.
Yes. Right ventricle pressure.
It's also raised,
Hmm.
and pulmonary artery pressure is also raised.
Pulmonary artery pressure. See pulmonary artery pressures.
It is 20. It's normal.
Yes. And you see the difference between ventricle and the pulmonary artery pressure. So
There
keep
is
it
a
in your mind. Okay, keep it in your mind. We'll back to the conclusion one by one. So now back to the left side. Pulmonary, left side, left atrium. So in our
Slightly,
left atrium, yes,
slightly
now
raised.
left. Okay. Left ventricle, 90/5. Okay. Or there is no difference. So that is okay. Okay. That is okay. So now I'm using my red color. Now tell me where is the problem, where I should mark it.
Problem is the
So
level
this
of
is all
right. First
right
problem is
where?
yes. Then there is a problem in the right ventricle because it's
Very good.
different.
Hmm.
It should be around 70, so it is raised. Can you let it step up?
Very good. And also we can see the pressure as well, right? Ventricle pressure also high. Okay. So right
Raised.
ventricle pressures are high. We can see that right ventricle saturation is also high. Okay. And when we goes to the pulmonary artery, over here there is a difference. There is a difference from the right ventricle. So we have all concluded right side. Now we back to left side. So left side, what you can see, there is a problem or not?
Left side seems almost normal.
No,
There is a problem at the level of yes, left ventricle.
Okay. So left ventricle saturation is less than 94.
Yes, there's a
That is
94.
why the same goes to the aorta around, and aorta saturation is also decreased. Okay.
Yes,
So this
yes.
is a problem. Okay. So over here the pressures are okay, but saturation is decreasing. Okay. So now you have detect. Now tell me, you have already tell me that there is a step up. Okay, you have already tell me up. See, step up at the right side. See, keep it in mind. Step up at the right side,
Yes,
saturation plus pressure. Okay,
yes.
pressure. But at the level, what is the level? Now you have to tell me the level. Where is that step up occur? At the level of the ventricle.
Ventricle levels.
Okay, so that
Yes.
means the problem of shunting is at the level, because how step up can occur only through the shunting. Okay, so it means that there is a what is there at the
Ventricular
level of ventricle. Very good. So ventricular septal defect. Okay, ventricular septal defect is there, and what you can see that almost, if you can see the pressure between right and left, if you can see the pressure between right
almost
and the left ventricle, they are almost
same.
same. Okay.
Yes.
So we have 4 differentials. Keep it in mind. But we want to see 4 differences. We'll keep those differences today. So what are those differences? What are those differentials,
Large
Ariba?
ventricular septal defect is in migraine syndrome and
Very good.
tetralogy.
Soft
Yes, tetralogy of Fallot.
or
Um,
truncus
truncus
arteriosus.
arteriosus.
Okay.
Yes.
So we are today, because we are dealing with the acyanotic heart disease, we have excluded large VSD. Okay. Because VSDs are the acyanotic heart disease. So now you are dealing with Isinger, cytology of Fallot, or truncus arteriosus. Okay. So now you have to exclude it one by one. I'm going to exclude it for you. Okay. So you have already decided there is a VSD. Of course, there is a connection. But when you see the pressure, the right ventricle pressures are high. That means that right ventricular hypertrophy. Okay.
Yes.
Do you agree with me?
Yes.
Right ventricular hypertrophy is there. And when you look at the pulmonary pressure, so pulmonary pressure is decreased. So if there is a pulmonary pressure is decreased, a difference is there. So that means you have pulmonary stenosis. Okay.
Yes.
So now this is the pulmonary pressure, which will going to tell you whether there is Eisenmenger or not. So if you have a same pressure, listen it very carefully. If you have a same pressures between the right ventricle and the left ventricle, then you look at the pulmonary. If the pulmonary also has a same pressure like the right ventricle, then that would be Eisenmenger. Okay? So if you have a difference, that this is pulmonary stenosis. If it is the
Oh,
same, just like the right ventricle, that it would be Eisenmenger. Because there is a difference, so it will going to rule out Eisenmenger as well. Okay. So when we
yes.
talk about the truncus arteriosus, so I'm telling you how you're going to exclude and how you're going to in the things. Okay. So when we talk about the truncus arteriosus is a single large vessel coming from the ventricle. You do not have separate pulmonary artery or the aorta. So the pressures will be same between the artery and the pulmonary. Is that so? Because you have a
Yes.
single large vessel. So because there is a difference in the pressures, so it means that you have separate vessels are there. It has separate pressure. It has
Yes.
separate pressure. So that rules out truncus arteriosus. So you are dealing with the cyanotic. It is
Tetralogy of Fallot.
associated with VSD, right ventricular hypertrophy, pulmonary stenosis. So your conclusion will be tetralogy of the Fallot. So your
Yes.
question should be, Dr. Aisha, why there is step down in the saturation in the left side. Why? You have to answer this. Why? Why there is a step down? There is step up. There is a step up. Step up
Yes.
means that blood is coming from left to
Left to the right.
right. And if there is a step down, that means the shunt is from right to left.
Left. Okay.
Will you agree with me? So blood is also coming in this direction as well. So in your VF, you have bi-directional shunt. So if you
Oh,
have left to right as well, right to left as well, so you called it bi-directional shunt. Is that okay now?
yes.
Clear every question, everything is clear. So in that way, you will going to interpret the, this is a very difficult question. You attempted, that's so great. You have learned a lot from this, okay? That would be a very
Can you
good
please
summary,
repeat?
which we have discussed.
Can you
What should I
please repeat
repeat,
how you
doctor?
explained it? How you explained it, Doc?
Sorry, doctor, I didn't get you. Repeat your question,
I
what
want
you
to
say?
know how you I want to know how you excluded Doc. Tetralogy of
How you
Fallot.
excluded top? Okay, no problem.
Yes.
See, top has 4 components. You will agree with me. The first is the large VSD, okay? The second one is the right ventricular hypertrophy. The third is the pulmonary stenosis. And fourth, the overriding of aorta, okay? So I've explained all these three in this picture. So let's make it this again. If you have a problem, no problem. See, I'm making it right atrium, right ventricle, left ventricle. Okay. So what I told you, when I make the saturation, write it 72 over here. In the left right ventricle, there is a saturation 84. Okay. And when we talk about the pulmonary artery also have same saturation. Okay. When we talk about the left side, over here it is 98, it is 91, and over here is 88. Now first talk about the saturation, okay? Then we will go through the pressure because that will make you easy. So I just take a separate color. I mark there is a problem over here because the blood, if it is coming from atrium into the ventricle, it should have same saturation. So at this level ventricle, at the level of ventricle, there is increase in the saturation. There is increase in the saturation means that something shunting is there. So shunting it, if it is there, that means VSD is there. So I've already tell one thing that VSD is there. Okay. So when we talk about VSD, we have explained. Now to look for the right ventricular hypertrophy and pulmonary stenosis, we will going to look for the pressures. Look at the pressures. What are pressures? So when you look at the pressure, you can see that the right ventricle, this is our right ventricle. Right ventricle pressure is 85. Okay, so right ventricle pressure is 85.7. Okay. And when we talk about from the right ventricle, pulmonary artery is arising. Pulmonary artery pressure is 20/8. So what I see over here that the right ventricle pressure is increased, step up, because normal right ventricle pressure is 25. Huh. Right ventricle pressure is 25, so it is increased, okay? And when we see the pulmonary artery pressure, it decreased. Normally what happened, there is a same pressure between the right ventricle and the pulmonary artery. Same pressures between the ventricles and the artery, okay? So there is a difference is created. So two things will be answered over here. Because the pressures is high, that means the ventricles are thick walled. Thick wall means it is right ventricular hypertrophy because of high pressures of the ventricle. And there is a difference between the ventricle and the artery. So it means there is an obstruction over here. So always remember pre-obstruction, before the obstruction, you will have high pressures because working against that, against that obstruction. And below the obstruction, or you can say after the obstruction, beyond the obstruction, you will have a less pressure because only a small amount of the blood can traverse through that obstruction. So because there is a difference, so that explains the pulmonary stenosis as well. And you can see the very important for aorta saturation less than 94. It again gives me clue that I am dealing with the acyanotic heart disease. So that is why this is stopped. That clear to you now, dear?
Yes, thank you so much.
Is that clear? You're welcome.
Yes, yes,
Doctor,
thank
okay.
you.
So what's your name? What's your name, doctor?
Tabinda. Tabinda.
Tabinda. Okay, now Dr. Tabinda, going to solve the third question, okay, third example with me, so it will be more clear with you, okay? So let's see over here. So this is just the summary which I write over here. So I'm just reading it. Saturation in the aorta is decreased, so I'm dealing with the cyanotic heart disease. There was increase in saturation at the right ventricle, so that means there is a shunt at the ventricular level. Because you can see that step up of the oxygen was increased in the right ventricle. You can see over here, Tabinda, that right ventricular saturation is increased. That means blood come from left ventricle to the right ventricle. Agree? Blood come from the left ventricle
Yes, yes.
to the right ventricle. That is why you
Yeah.
have saturation is increased. But when you see the left ventricle, this is left ventricle. Over here, there is a step down. There is a step down. So if someone's saturation is decreasing, that means the cyanotic blood, the deoxygenated blood is mixing into the left ventricle. So the deoxygenated blood is present in the right ventricle. That is coming into the left ventricle. Okay. So right to left shunt is also there. So if any condition in which you have both left to right and right to left, both are present, this is called bidirectional shunt. Agree, Tabinda?
Yes.
Very good. Okay. So that's what I'm saying, that because at the level of the left ventricle, there is a step down. So shunting also at the ventricle, but it is right to left. That explains that the bidirectional shunt. Third important thing we explain is that if you see the pressure between, the right ventricle, if you see the pressure between the, see how you detect the bidirectional stars. I told you to see how I just explained this is be with me, okay? You will be clear. See what I told you, that see the saturation. Whenever you are want to check the shunt, you want to check the shunt, whether this is left to right shunt, whether this is right to left shunt, whether this is bidirectional, you have to check the saturation. So when you see over here at the level of right ventricle, there is increase in the saturation. So increase in the saturation means oxygenated blood from the left side come into the right ventricle. You will agree with me, Saad. You agree with me for this?
Yes, madam.
Saad, you are okay. Now look at the left ventricle. See, this is left ventricle. over here there is a step down occur. Your saturation should be more than 94. So over here step down. Step down means deoxygenated blood from the right side came into the left ventricle. Will you agree with me over here as well?
Yes, madam.
So in a VSD where both shunting is occurring left to right is as well, by looking at the right ventricular saturation, and right to left shunting by looking at the left ventricular saturation, you can see both type of shunting is going on. So that is why you will going to see directional shunt. Now clear?
Yes, madam. Thank you.
Clear? Okay. So in that way, you will going to interpret about the shunting. Okay. The third thing, Tabinda, what I was telling you here, that you can see the right ventricle pressure. This is the right ventricle pressure, and you can see left ventricle pressure. Can you see the significant difference between it?
No,
No.
no,
So
not.
if the both sided pressures are almost equal, so you have four differentials, which I told you. TOF, truncus arteriosus, you have large VSD, and you have Eisenmenger syndrome. Okay. So that's what I'm telling you if you have the same pressure. Because we have already established the pulmonary stenosis and right ventricular hypertrophy. So we mark the TOF over there. Okay. So now, Tabinda, now this is your turn. Let's start with it. This is a small question for you.
Okay, the aortic, the first thing we will look at is the aortic pressure, which is 98.
Very good.
It's most likely acyanotic.
Very good.
And then we go through the flow of the saturations first. Left atrium is 98 and left ventricle is 98 as well, and these are normal. When we come on to the pressure, the left atrial pressure is 10/5, and the left ventricular pressure is 152/60, and the aortic pressure is 90/50. There is a major step up at the level of left atrial pressure. And then
this is not major, doctor. This is not major. This is not 5 to 10. I told you 8 is the normal for left side. This is not a major. So let's assume it's normal,
yes.
okay?
Yes. At the level
Okay,
of the left
let's
ventricle,
assume.
I'm sorry.
Right. Okay, no problem. Very good. Very good. And
And the
there is
aortic
a
pressure
pressure is step up,
decreased,
and what you
slightly
can
decreased.
see, and what you can observe, two things are there. First, you have detected, very good, there is a step up of the pressure at the left ventricle. Second thing, what is there?
Can we call the aortic pressure decrease in this situation?
Pressure difference. You can use the word difference.
Okay.
Am I right? You can use
There is
difference or not?
yeah.
There is such a big difference. See, 60 millimeter is such a big difference. So big difference between the ventricle and the artery. So what is this condition? Now concluded.
Could be due to stenosis.
Very good. So what type of stenosis?
Aortic stenosis.
Stenosis. And we are dealing with the aortic stenosis.
Yeah.
Okay.
Yeah.
Very good. Now clear, Tabinda?
Yes.
Very good. Now who will going to do the next question? So same thing, stenosis could be, it is coarctation, could be stenosis. Same thing, okay? Coarctation of aorta, or you can say aortic stenosis, means difference between ventricle and the artery level, okay? Same thing. Okay, who will going to do this example?
Madam, I'll do the next.
Could you try? Let's ask with Dr. Rabia because he didn't try. Rabia, can you try it? Let me take one call. I'm just coming. Just give me. Abhi nahi, I'm taking class. Arbat, Don't try. Rabia, are you there, Rabia? Ma'am, I can't. Okay, no problem. That's why I'm asking. Okay, Saad, you can take this example. Okay, Saad, let's start.
Okay, madam, first we are looking at the saturation of aorta, which is 35%, which is low. So this means this is probably a cyanotic heart condition. Now looking at the saturations, vena cava is 30%, which is much low. RA 32, RV 32, both are low, and there is a major step up at the level of pulmonary arteries. The saturation is 92%. And on the left side, the saturation is low, slightly low in LA, and it's almost normal in LV. Now looking at the pressures, the pressure on the RV is 90 by 100, which is raised, and pulmonary artery, there is low pressure in the pulmonary artery. LA pressure is almost normal, and there is um, decrease difference of pressure between LV and aorta.
एक मिनट आप लोग ना don't conclude it right away, because first try to just write it down, then we will discuss step up, step down. Okay, otherwise it will be confusing, because everyone has own level of understanding. So we are talking about first the saturation, now we're talking about the pressure. Okay, so this is
Yes.
the right ventricle pressure is 90 by 10. Okay, and when we see the left ventricle pressure is 60 by 7. Okay, everyone agree? Now we talk
Yes.
about pulmonary artery. Pulmonary artery
Yes.
pressure is 60 by 7. And when you see the aorta pressures are 88 by 60. Okay, now Saad, is this clear? Now I write it properly. Okay,
Yes.
now I'm taking my blue color. Now tell me where is the problem with the problem. So problem is over here, problem is over here, significant. This is the
Yes.
right side. You cannot expect that much high pressures, 90. Okay. Problem
Yes.
of the saturation is also over here.
Yes.
Is a significant increase. Okay. Pressure difference is also over there. When we talk about left side, 93, I'm assuming okay. 95, I'm assuming okay. But what I can see over here, sorry, let me write it 35 over here. So what I'm assuming, the saturation is over here 35. Pressure is over here is different. So what you
Yes.
can see, where is the problem, Saad?
Uh,
Keeping in mind you are dealing with a cyanotic heart disease.
yes,
Cyanotic,
madam.
sorry.
Madam, there is considering the condition, I think this is TGA.
Very good, very good. So Asad is absolutely right that if you see these compartment very carefully like this, see the right ventricle and the aorta. Right ventricle and the aorta both are exactly same. Saturation C, right ventricle 32, aorta 35, right ventricle pressure 90 by 10, aorta pressure is also around 80 by 60. So you can see these two compartments are almost same. So that means from the right ventricle, aorta is arising. Okay. And if you compare these two compartments, this from the left ventricle to the pulmonary artery, saturation 94, 92 almost same. Pressures, if you can see the same, that means from the left ventricle, pulmonary artery is arising. This is called transposition of great arteries. That's great. Is that clear to everyone? Then I'm going to move on.
Yes.
It's clear.
That's great. That's great. Alhamdulillah. Okay, now next example. I think we have a next example as well. Okay, next example. So you can read by yourself. I've already explained this. So I think we are left with only one more example. Who will going to do it? Who will going to do it? Yes.
I'm going to do it, ma'am.
Reba, would you try?
Yes.
Okay, let's do it.
First, we will
Do
see.
it.
First, we will see the population of aorta, which is less.
Very good.
We are dealing with heart disease. Then we will
Cyanotic. Very good.
Then we will see all the saturation in right atrium, 55%. Right ventricle, it's also 65, and pulmonary artery is 68. And it's almost touching the normal value, 70%.
Very good.
Then we will move to the left side. Left atrium is 95, left ventricle is 82, and aorta is 83. Left atrial saturation is fine, but left ventricle saturation is decreased, and also aorta is decreased. We will
Very good. Very good.
pressure in the right ventricle is 90/10,
Right
which is
ventricle. Right ventricle. Okay, this is right. हाँ, ठीक है.
raised, and pressure in left ventricle is 100, and aorta is same. So problem at the level of, there is a problem.
Yes, of course, problem is there.
Left atrium and aorta.
Okay, where
Right.
is the problem in pressures, Rariba?
Pressure at the level of ventricle.
Which ventricle?
Left ventricle.
Left ventricle problem is there.
No. Pressure is right ventricle.
Very good. Right ventricle. See, it's more than 25.
Yes, right ventricle problem. Yes.
Very good. See, pulmonary pressures are 100. This is also abnormal. Okay.
Yes.
So now you have marked the abnormalities. Okay.
Yes.
Now tell me where is the, now try to, interpret one by one. So what do you think, where is the problem? First start
Step
with this
down.
saturation problem. So what happened
Saturation.
over here? Step down.
Down. Yes.
Step down. Everyone will be agree. Tabinda, you will be agree that there is a decrease in saturation from 95
Yes,
to
there is.
88. Okay. So why
Yes,
this
yes.
occur? Why this occur?
It may be due to mixing
Due to
Because
of blood.
mixing
shunting.
of blood, shunting. Very
Shunting.
good. So there is VSD. Can you tell me the shunt level? Direction of shunt?
This is
Bidirection.
right to left.
Very good. Because from the deoxygenated blood mixing into the oxygenation, that is why it is decreasing. So right to left shunting is there in the VSD. Keep this in
Yes.
mind. VSD with right to left shunt. So you have explained this point. Okay. Now talk about the pressure. So the pressure is raised. Okay. So pressure is raised means that the ventricles are strong. Is
Strong.
that so?
Yes.
Ventricles are strong enough. So right ventricular hypertrophy obviously there. Okay. And when you see the both pressures, you can see the such a big difference is there or not?
Yes.
No such big difference between the right and left.
Only 10% difference. Almost same level.
Only 10. Almost same. Okay. So just keep in mind the 4 important differentials. Then look at the pulmonary pressures. What do you talk about pulmonary pressures? Pulmonary pressures are raised or decreased, or there is any difference between it?
They raised.
They are raised.
Raised, and there is no difference between it. So this is pulmonary hypertension. Would you like it? Would you like to say pulmonary hypertension?
Yes.
So just conclude it now. What is this? Cyanotic, VSD,
Persistent
right to
pulmonary
left shunt,
hypertension.
right ventricular hypertrophy, pulmonary hypertension. So what is this? I've told you. I've
Right
told you. If
Ma'am,
Is that one?
Eisenmenger.
Eisenberger? Yes.
very good. Very good, Ariba. This is right ventricular hypertrophy with Eisenmenger pulmonary hypertension occur. Once pulmonary hypertension occur, now this becomes irreversible condition. You are going for heart transplant and lung transplant. Okay.
Yes.
So I think it is clear to everyone. I'll send some practice material for you as well. You can practice it by yourself. Otherwise, we have done almost many conditions. Okay. So this is also asked in exam that what is about Epstein anomaly. So Epstein anomaly is basically a very, very large right atrium. Okay. Very, very large right atrium. And you can see such a large heart is there, cardiomegaly is there, and it is associated with intake of lithium. This is exam question. Okay, so lithium is associated with Epstein anomaly, and in which you have a very, very huge right atrium is there. Okay. Okay. So now we talk about the ECG. Okay. So I think everyone is cleared with the cardiac catheterization now. What's the time? 3:30 is there. Okay.
Yes.
Just 1 minute. I'm just starting with the ECG. Just a minute. So. Okay. So now change the mind with the ECG. Okay. So we're going to discuss it because we are left with half an hour. We're going to just try to solve it, try to discuss as much possible. Okay. So when we are dealing with the ECGs, we will going not to going discuss in detail, but definitely the exam related things which are in exam, because in your, when you are looking or your cases, they are associated with different of long QTs, SVT. So that is where there is a need to discuss a little bit for your exam purpose. But definitely in our AKP exam, this ask in detail. So over in that, in AKP, then I'll give you the lecture accordingly in the AKP section. So let's start. When we are talking about the ECG paper, when we are reading so the ECG paper, we have two types of electrodes are there. One we call are the precordial chest electrodes, precordial, and we also called it as the chest leads because they are applying on the chest. And you can see over here that this is your sternum. V1 is applied on the right side of the sternum, while others from V2 to till V6 all is applied on your left side of the chest. This is called precordial chest leads. When we talk about the limb electrodes, the limb leads, they are applied in all of your limbs, the right limb, the left limb, the right leg, the left leg, and they are on the ECG, they are written as, you know, 1, 2, 1, 2, 3, 1, 2, 3, AVL left, AVL left, AVR right, and we have AVF. Okay, so we have these 6 leads are for the limb leads, and these 6 leads are for the precordial, and total we have 12 lead ECG. Okay. Okay. So this is just 12 lead ECG is there. Now we will going to talk about, I've already told you there we have total 6 chest leads and 6 limb leads are there. Now the important thing is that why in some leads you can see in this picture that why you can see there is a change. Can you see the difference between this lead and this lead? What you can see, if you can look at closely, look at direction of the QRS, especially in the T wave. See the T wave, QRS wave, the direction is different in the different leads. In the AVR, if you are looking at the AVR, the direction is different. It is downward. If you see this QRS, it is in the downward direction. But if you look at lead 2, you can see that there is an upward stroke of this QR wave. So why this is different? So this is different because of the direction of the current around the heart. Okay, so because leads are looking from different angles, so where if there is a direction of the current towards the lead, what I'm saying, if your electricity, if your current is traveled towards the lead, then it will give a positive deflection. If it is away from the lead, it will give you a downward deflection. So we all know that our cardiac electricity is going in this direction, towards the left side. Why? Because towards the left side, because of the prominent left ventricle. Okay. So those leads which are placed over here, okay, those leads who are placed over here on the right side, like AVR, which is present on your right side, VVR, which is present on the right side of the stirrup. In these two leads, your direction of the current is away because these leads are over here and the current is moving away from it. Okay. That is why they are giving negative deflection. They are negative deflections. While other lead, for example, you can see the V6 will give you total positive deflection. V5 will give you total positive deflection because the current, the electricity is completely towards these leads. Is that so clear? That is why you see. So whenever you can see, you just discussed where if in the V1, this V1 is very specific to look for the right ventricular hypertrophy, to look for the pulmonary hypertension. So what we learned is that normally in the V1, you can see because this is the right side and our electricity is more towards the left side. So you can see normally you find downward deflection of the QRS wave. You find the downward deflection of the T wave. But if it become in reverse, if you find that upward deflection in the V1, that is shows right ventricular hypertrophy. If you find upward deflection of your T wave, that shows pulmonary hypertension. Is that so? So that is why it is very clinically relevant. So most of heart diseases, most of the problem we can look at by seeing the ECG. There is no need always to go for the echocardiography. So whenever you look at the ECG, most of the time it will give you clue that there is something going on. If you find out that the V1 has a positive deflection, that means that the right side predominant. Why right side become predominant? Why? So you can see in the TOF patient, the right side become prominent. So in that you can find out the V are in the V1. So in that way, you can, diagnose, you cannot diagnose, but you can, get an idea that there is something problem going on because the right side is predominant in this ECG. Okay. So now this is a ECG paper in front of you and how these ECGs are, you can see the ECG, it is written over here. So in this picture is not very clear. So we will, but over here, the main view is that, so how leads are seeing different views. So when you look at the heart, you can see the heart from the anterior surface, from the lateral surface, and from the inferior surface. So these are the three. That is why we say that, lateral MI, anterior MI, inferior MI. We use these words, okay? Because these are the three views you can look at the heart. So which lead responsible for that? So if you can see over here, first talk about the lateral side because the left ventricle is predominant. So the most lateral leads are these. Most lateral leads are this. That is, you can see over here, the most laterally placed are your AVL, you can see 1 and V5 and V6. This is most laterally placed, okay? So this look at laterally your heart. 1, AVL, V5, V6. If you find any changes in this ECG, means the problem more towards the left ventricle, the lateral side of the heart. The anterior side is mainly by your chest lead from V1, this chest leads. This is from this V1 to V4. So the anteriorly placed precordial leads, the chest lead. From V1 to V4, they are looking the chest from the anterior side. But if you see these three leads, which is placed inferiorly, 2, 3, and AVF, these three leads looking the heart from the inferior surface. Is that okay? So you have to remember these which leads are responsible for which side. So I've already make it easy that the left arm, the V5, the V6, and 1. So this is laterally, V1 to V4 is anterior, while 2, 3, and AVF is the one which is looking at the heart from the inferior surface. Okay, now we talk about the cardiac axis. One of our question was related to the cardiac axis, and at that time I just hold it. So now I'm going to explain about the idea about the cardiac axis. So cardiac axis is basically telling you about again the direction of the current. So what do you mean by this axis? An axis we are talking about. So by looking at the axis, we know that where is the direction of the current. And once we identify the direction of the current, we get the idea that whether our left side is predominant or the right side is predominant. Okay. So normally what I told you, our current is lying somewhere around over here. Okay. So the normal axis is shaded with the pink color. So normal axis is shaded with the pink color. So we have a degree. So what is the normal degree for the normal? So just remember this, that this is the one which you have to remember. This is the 0 degree. Everyone can remember it. Okay, 0 degree. And this is our 90 degree. I think you cannot forget it. 0 degree. This is our 0 degree axis. This is 90 degree axis. This is our 180 axis. Okay. So when we talk about 0, 180, 90 degree, so this part is our normal part, but normal part is little bit more extended over here up to, so when we goes in this direction, so you can see -10, -20, -30, and in the center it is -90. Okay. So below it is +90 and above is -90. So from -30, -30 to 90, this all is our normal axis. From -30 to +90, you have to remember because your question was asking to related to the degrees. So that is why you should have an idea that from +90 to -30, this is our axis. Now just make again this thing. Let me try to make it simple. Just a second. So this is the picture, okay, in front of you. So you can see over here, just make it simple. This is our 0 degree, okay, so let's make it. This is our 90 degree positive. This is our -90 and this is our 180, okay. So we all know that this part is come under a normal, okay, so normal axis. If our axis is somewhere in this portion I'm talking about, so that means this is left axis deviation. So if you want to interpret it in terms of degrees, so remember in the negative that -30 to -90. -30 to -90, this is left axis because they can ask in degree as well. So that is why you should have exactly idea that -30 to +90, this is normal axis. -30 to -90, this is left axis. Then talk about over here that this is our from +90 to +180, this part. +90 to 180, this is right axis deviation. And then this part, this is called extreme axis deviation. Extreme axis deviation. Extreme axis deviation. Is that clear? Or you can say extreme right axis deviation as well. This part is over right axis. This part is all about right axis. This part is about normal or left, because our heart is left side prominent. So this part of the circle is the left. This is the normal, and from -30 to -90, this is left axis deviation. Other than that, this part of whole circle, this half part is right for right axis deviation. One of the term you was encountered when we were discussing the ASD, that was superior axis. Okay, so what is that superior axis? Another name of left axis deviation. Another name of left axis deviation is called superior axis. Now, is that clear to everyone what is superior axis? It is, as you can say, it is also called as left axis deviation. Is that clear to everyone? So when we talk about more than 90, more than 90 called right axis. Beyond -30 to -90, it is called left axis. And from -30 to +30, this is your normal axis. Is that clear? Any question? Saad, Tabitha, any question? Ariba? No question? No question, that's it, okay? Now now we will going to interpret. Okay. So now how you going to interpret it? Okay? Little bit a clinical part, even though they will not give you ECG to interpret it. They just concentrate for your task part is this. Okay, these numbers you should know for your task exam. Okay, this part is for your AKP part. Okay, but I can over here a little bit give you idea about it. But if you don't understand it, if you cannot keep it in your mind, no worries. Okay, so this is an extra part for your AKP, because unless ECG will not be in front of you, you cannot tell about the axis. And ECGs will be given in your AKP exam, not FOP and TAS exam. Okay. So when we are looking at the axis, this is your ECG reading part. When you are looking at the axis, always start with two leads, that is lead 1 and lead AVF. Okay, lead 1 and lead AVF. So I've already told you that whenever you are looking at ECG paper, all numbers are written. You can see this is your lead 1, this is your lead 2, this is your lead 3, this is AVR, AVL, AVF, V1, V2, V3. It is written. Okay, so this is all written in your ECG paper. So you have to look for two leads for looking for the axis, lead 1 and lead AVF. Okay, so this is AVF. You start with lead 1 and lead AVF. What you looking at it? Positive thumb sign, two positive thumb sign. So two positive means just like when you thumb up. When you two thumbs up. When you two thumbs up means when positive deflection in lead 1, thumb up, or when you positive deflection in the AVF as well. So this is AVF. So in the AVF, positive deflection, double thumbs up, double thumb up, double thumb up. This is for normal axis. For normal axis, just start look with 1 and AVF. 1 means positive. AVF is also positive. That is normal axis. Now, someone cannot remember it this way. Right? So we have another way as well by making this diagram. How I make this diagram? I'm trying to make it simple for you. So lead 1, always, this is your lead 1 at the 0-degree level. Lead 1 is your at degree level, and lead AVF is at 90-degree level. Okay, 1 is 0-degree level, AVF is at 90-degree level. So when you see over here, what I told you, so just make a little circle over here. Just make a little circle like this. So write a lead 1 over here at the 0-degree. Okay, this is 0-degree. And this is your 90-degree for AVF. Okay, so make it this. Now, if our positivity is there, okay, It means that because lead 1 is looking like this, see, please listen it very carefully. If lead 1 is looking at this side, okay, so the positive of lead 1, please listen, positive of V1 is of whole this side, okay. So if lead 1 is positive, the current direction would be somewhere in this whole half quadrant, okay, in whole this quadrant. If lead 1 is negative, if lead 1 is negative, then the current direction will be around either in this quadrant or in this quadrant. Because this is the 0, this is the positive part, this is the negative part. So whole this is the negative. If you have negative deflection means if your QRS, this is your QRS, if the direction of QRS is like this, in the downward direction, just like in the V. If you see the V1, this is the downward deflection. And if you lead 1, this is upward deflection, okay? So upward deflection means current direction, I'm not sure. I just look at the one lead now. The current direction could be here, could be here, could be here, could be here, could be here. I don't know. It could be anywhere in this quadrant once we look at the lead 1. But we know that if the current direction is over here, it could be left axis. If it is over here, it could be normal. So that is why there is a need to add the 2 leads. One lead cannot tell you about the axis. You have to look at for 2 leads. So now I go to look at the AVF. Now I'll make AVF. So you can see AVF in the positive direction. This is positive direction. So hold this downward is positive. So in the AVF, if it is a positive deflection is there, current could be over here, current could be over here, current could be over here, could be over here, any downward direction. If it is negatively or if in the AVF you have a negative deflection like a V1, that means current is in upward direction. Could be here, could be here, could be here, could be here, in the upward direction. Okay, so we just got the idea. Now we have to combine it. We have to, and we see where these intersecting. So now I'm making another diagram to make things clear, okay, by using different colors so that we'll see the intersection. So now see, this is the whole circle, and we all know that divided into 4 parts. We know that lead 1 positive over here, hold this part, and lead 1 negative is over here. When we talk about the AVF, positive is in the downward direction and negative is -90 in the above direction. Okay. Now, when we look at the lead 1, that is positive. I am assuming that probably current is whole, could be in whole this circle. Okay. When I look at the AVF, AVF is also positive. I'm seeing current could be whole throughout in this direction because AVF is positive. So tell me, quadrant is intersecting for both of leads. So if you very clearly look at this side, if you look at this side, both leads are intersecting in this quadrant. And this quadrant is completely made for normal axis. Is that clear to everyone?
Yes.
Please speak up. Is that clear?
Yes.
Okay. So this is the normal axis. So you just, by seeing the 2 leads, you see the intersection and then decide where our current is. So this is the normal axis, current in the left side. Okay. In this way, or you can see a double way, double thumbs up. Okay. So now look at this right X. Now what happened? In the right side, always remember the right side, right people. So just remember the right side, the right people with the number 1. So just remember that number 1, the righteous people, ritual, अच्छे लोग, number 1. So just for your memorization. Number one, people. So the changes would be in the lead one. For right axis, the changes would be in the lead one. Okay. So the lead one would be negative. So over here, you can see, if you can see over here in this QRS, little positivity and the negativity is there. So always look at the major difference. Where is the major positivity or major negativity? So over here is the major is the negativity, downward deflection. E1 is negative and AVF is positive. So the what I say, righteous number one people changes in the lead one. The lead one will be in the downward. So just make it quickly, make this circle as well for you people, just for a memorization. So what I do, so just I made AVF positive 90, minus 90, lead one. So this lead one positivity over here, negativity over here. Because this one is in the downward direction, I'm assuming could be over here, over here, over here, over here. This whole part is negative for lead one. Now look at the AVF. When I look at the AVF, I found it is upward. Upward means someone in downward direction. Someone. Where it is intersecting in this quadrant. This quadrant is made for right axis deviation. Okay? Okay, people. So we move on. Now look at the
Yes.
extreme right axis. In extreme right axis, because it is extreme situation, so both are negative, double thumbs negative. So normal, double thumbs up. Normal, double thumbs up. And in extreme, both thumbs are negative. Both thumbs are negative. This is also negatively downward. And if you see the AVF also negatively downward, okay? Now, when we look at the left axis, this is a little bit tricky over here. Over here, what is the problem? So if you look at this quadrant, in this quadrant, the pink part is also there of normal part and green part is also residing for the left axis. You with me? You agree with me? In this quadrant, because normal is also residing and green part, left axis is also residing. So over here, if you want to label about the left axis, leads will not be enough. You have to look at the third lead. The third lead is the lead 2. The third lead is the lead 2. You have to look at this lead 2 as well. Okay. So if lead 2, if you make the lead 2 downward direction, if you see the lead 2 direction, it is in the downward side, just like the AVF. Just like the AVF is also on the downward. 2 is also on the downward. If 2 is also positive, that means this is normal axis. If 2 is negative, that means your axis is lying on the above side, probably left axis. So let's start with it. So obviously in the left axis, what I told you, for people, the righteous people, the changes would be in the lead one. For the left people, the changes definitely in the opposite lead, that is AVF. So AVF would be in the downward direction. You can see the AVF is in the downward direction. Lead one is upward, okay? AVF is in the downward direction. I've already explained, but two lead not be explained. AVF, if you make a circle like this, let's the circle 0 degree, 180 degree, plus 90 and minus 90. So if your lead one is positive, that means you are somewhere here and there, here and there, here and there. But if your AVF is negative, that means you are in the upward side, upward side, upward side, upward side. Now you have explained that this is the quadrant intersecting. You all agree with me. But now the answer is that in this quadrant, not only the left axis is residing, little part of the normal is also there. You can see little part of the normal is also there. So for that, you have to look along with the AVF, which is on the negative side, you have to look the lead 2 as well. If lead 2 is also negative on the upward side, if lead 2, you can say like this. If it is on the upward side, that means the axis is normal. If it is in the downward, just like the AVF, if you look at the lead 2, just like the AVF, if it is also downward, that means your axis is left axis. Is that clear? Is that clear?
Yes.
Okay. So this is very, very important to look at for the axis. If they will give you in numbers, you should know this diagram as well. You can tell in numbers. So just remember the word minus 30 to plus 90. This is the normal. Beyond positive 90, it is all right axis. Minus 30 to minus 90, this is your left axis. In that way, you can tell about the axis as well. Okay. So when we talk about the ECG calibrations, I think we can discuss ECG calibrations and arrhythmias tomorrow, because I have to make some preparation for iftar as well. So we will inshallah discuss tomorrow at 2 p.m. We'll discuss the ECG, because I've given you so many concepts. It will not take us so long, and we will discuss inshallah recalls questions as well along with it. Okay. If you have any questions up till now, you can ask me.
Sorry, madam, I
No.
had one question.
Sure.
मैडम बेसिकली मुझे ना ये समझ नहीं आई कि ये जो एक्सेस है माइनस और प्लस, ये हर लीड के अकॉर्डिंगली होते हैं, या फिर ये एक मतलब ये मुझे समझ नहीं आई, मतलब माइनस का क्या
हर
मतलब
लीड
है,
के
प्लस का क्या
नॉर्मल जो
मतलब
होता
है?
है ना डॉक्टर साहब, जो द नॉर्मल इज फिक्स्ड फॉर एवरी lead. The normal
ठीक
is
है।
fixed. Okay. So you can see in the normal individual, the V1, you can see lead 1 may you will get the positive deflection.
जी
Okay. This is normal. Okay. And in the normal person, when you look at the V1, that is normal, that deflection is in the downward direction. Okay. This is
यस
normal because of the arrangement of the leads, how you are looking at the heart. Okay. Cameras
यस
views are different. Okay. When you look from the side, the view is different. When you look at from the interior side, the look is different. Is that so or not? You agree with
यस
me?
यस
Okay. So leads just like the camera. So leads which are on the lateral side, okay, they will give you positive difference. Because your current is more towards the lateral side, towards the left ventricle, because left
यस
ventricle is thick, predominant. Okay. So
यस
this is the
यस
normal, because right V1 is looking from the right side. So for the right side, the current is opposite. It is going towards the left. Okay. You are standing on the right, current is going towards the left. So because current is going away from this lead, that is why you get the negative deflection.
यस
Same with the AVR, it is placed on the right side of your limb, so it also detect negative. So this is fixed for these specific leads. You
यस
can see inferiorly AVF, this is positive. Lead 2, this is positive. This is fixed. But once you look at now, abnormalities are also there, na? This is normal that our left heart is predominant, but in the top, the right heart become predominant. Okay, na? When we talk
यस
about Eisenmenger, the right heart become predominant. So now the things will going to be changed. So when you look at it, the right side is predominant, then axis would be right axis. You got it? Your
ओके मैडम,
axis would be, axis means
राइट
direction of the current. So it would be
यस
towards right, like this. It would not be like this. No, it would be like this towards the right side. So that is why we are looking at the leads to look at the direction. So main leads are lead 1 and the lead AVF. That mainly tell you about where the direction of the current. You got it?
यस
So normally both thumbs up. You can see both leads are positive. Both.
यस
If you cannot recall it or understand it, in no problem. They will not give you VCGs. You just remember the numbers which I told you, that your normal from minus 30 to plus 90. Okay.
यस
Both thumbs up, both thumbs up. This is normal. Both thumbs down. If lead 1 is down, AVF is down, this is the extreme, because The negative means current is totally away from it. You got it?
Yes.
Current is totally away from it. So both leads would not be like, they will be like this. You got it? The QRS will be like this. So both terms will be negative. This is extreme right axis. Okay. And just
Yes.
remember, if only lead 1 is negative, EF is okay. So what I told you, right people, number one people means right people. So right changes if only right axis is deviated, then in lead 1, the changes will be there. AVF will remain same. Okay.
Okay, madam.
Ma'am, one question.
Okay. So if you, yeah.
Not related to the ACG, it's clear. I'm talking about the documents and can we solve these documents in class? Because I'm still finding it difficulty to solve
Which
the
document,
document
doctor?
FOP FOP cases recalls. I think you have sent in the.
We will discuss in
Question
class. Every question will be discussed in class.
Okay.
These are the most important part. Recall is your most important part. Each and every question will I'll discuss it like this. Okay?
Okay.
Don't worry about that. Okay, I didn't complete my lecture. That is why you find it some difficulties. But I'm going to discuss each and every question. Okay? Okay, sir.
Thank you.
So up till now, please listen the recording as well. If you find it difficulty, please listen it. But if it is difficult, leave it. For me, leave it. This is the AKP part. We're going to practice it. We will give you different ECGs. That way, the things will be crystal clear. Okay, so that is not a part for your domain. So I just discussed because ECG we came across with so many times, and when we especially discussed with the heart, we don't know about the ECG. So that is why I explain it. But tomorrow I'll going to explain different arrhythmias because they are asked in your talk about. They basically talk about them. So how you going to detect it? Because these are life-threatening emergencies. Okay, and every physician, it is not need. You don't need a cardiologist to detect life-threatening situations. You got my point? Life-threatening should be detected by each and every physician. Okay, it is not fixed to the cardiologist. So that is why we will going to discuss the most important, things, the emergencies, so that it will be important. We will not give you ECG to detect it, but that would be helpful for your clinical purpose. Okay. So we will come back inshallah tomorrow. If still you have a problem, just listen it again, this recording. Still you have questions, you can ask me tomorrow. Okay. Okay, Dr. Sir.
Okay, madam. Thank you.
Thank you so much. Thank you so much. Jazakallah and Allah.